pause my recording.
The introductions, and then that'll give a few other people a moment or two to join in. But for everybody who is here on the dot, welcome to the grandest of rounds, the CHEO Grand Rounds. I, as the program director for the Pediatrics Residency Program, get to introduce our speakers today. I will start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. I'll note that land acknowledgements are not meant to be a script so much as a bit of a personal experience, both for the presenters and for the audience. So what I'll do in this scenario is just ask people to reflect a bit what it means to them to honor a people while at the same time living on territory that is unceded. So we can think a little bit about that. And the purpose of doing these acknowledgements, I think, is to make us think a little bit about that every time we meet. All right, now to introduce our presenters. So I have four of our residents here: Dr. Zachary Blatman, Dr. Nia King, Dr. Catherine Lajoie, Dr. Jasmin Paget. As far as the bios I was sent, I'll tell you that Doctors Zachary Blatman, Nia King, Catherine Lajoie, and Jasmin Paget are a group of third-year pediatrics residents at CHEO. They are passionate about promoting patient-centered care and will all be pursuing fellowships within various subspecialties. And I'll note that they're staying local. So Zach will be doing HEMONC here in Ottawa, starting not the next academic year, but the one afterwards. Catherine will be starting in the Ottawa NICU, Jasmin in the emergency department here at Ottawa, and Nia is going to be serving as the foundation by pursuing general pediatrics. All right. The title of the presentation, Conversations That Matter, Navigating Goals of Care in Pediatric Serious Illness. I'll let them take it away.
Sorry, I was trying to unmute myself. Thanks, Dr. Herman, for that introduction. As Dr. Herman said, our grand round today is going to be about conversations that matter, navigating goals of care in pediatric serious illness. And so in terms of our learning objectives today, we're hoping that by the end of the session, participants will be able to describe the principles and purpose of advanced care planning and goals of care conversations in pediatric populations, to summarize some of the key recommendations from the 2024 CPS position statement on goals of care conversations and advanced care planning for pediatric patients living with serious illness, to recognize common challenges and barriers to effective advanced care planning discussions from both clinician and family perspectives, and also to review approaches to initiating and navigating complex goals of care conversations through case-based examples. And we'll be discussing two cases today during our presentation, the first of which is going to be talking about age considerations when engaging in advanced care planning, and the second of which is going to lead into how advanced care planning can ultimately lead into end-of-life care. So before we dive specifically into talking about goals of care and advanced care planning, it's really important to recognize the overall context of how the medical landscape has changed and continues to change over the last several decades. And so because of medical advances, more children than ever are living with chronic and complex medical conditions, and many of these children would not have survived in the past. And so as many of us know, these children's health is quite fragile and they may require multiple interventions like hospitalization or technological support at home to support their health. Because of this, these patients' families are often inundated with difficult decisions about which interventions are in their child's best interest and how best to enhance their child's quality of life. Given the potential for some harm from unnecessary or low success interventions, it's really emphasized now that it's the healthcare provider's responsibility to help guide medical decision-making for families, really with the goal of adding life to the child's years and not simply years to the child's life. And so the Canadian Pediatric Society recognizes the importance, but also the difficulty of advanced care planning for pediatric patients. And so they published a statement in March 2024 to assist providers in having some of these important conversations. And we'll really be using this as the backbone to our presentation. So what exactly is advanced care planning? As defined by Spicer et al., which notably includes some CHEO palliative care physicians, Dr. Davies and Dr. Vadabonker as authors, advanced care planning is a process of discussions between family and healthcare providers about preferences for care, treatment, and goals in the context of the patient's current and anticipated future health. So in shorter terms, it's really a process that seeks to explore the values, beliefs, and wishes of a patient and family to help support and guide informed healthcare decision-making that aligns with what matters most to them. Within this process, the child and family share with the clinical team their understanding of the child's current and future illness, their values, goals, and hopes given the child's medical status, and that what they believe the child might experience as a benefit or a burden in terms of interventions. The care team's responsibility is to share with the family knowledge about the child's condition, their prognosis, and the potential efficacy and benefit, or the burden of various interventions. And then based on this combined information, really the overall objective is to determine what the overall goals of care are given the child's medical status and to make recommendations on what interventions should or should not be provided. What's really key here as a first step is ensuring that the patient and family understand the illness of the patient, because that's really the foundation for making the advanced care planning. The process should be based on principles of shared decision-making and really be a dynamic and iterative process over time, where the conversation is frequently revisited, especially as health changes occur, and to allow for adjustment as a patient and family's medical status, circumstances, or values may change over time. And so one of the first steps of advanced care planning is starting discussions about goals of care to capture what is hoped for from medical interventions. And so goals of care really are the overarching aims of medical treatment and help outline what the patient and family hope to achieve with the care provided. And the CPS statement outlines that goals of care really fit into 3 different categories. So here they're labeled as prolonging life, as much good time as possible, and focus on comfort care. In truth, these categories really lie along a continuum, which I've illustrated here. So at one end is the goal of prolonging life, where all diagnostic and therapeutic tools would be harnessed, provided that they are believed to be in the child's best interest. At the other end is the goal of maximizing comfort, where investigations and treatments that don't meaningfully add to the comfort of a patient's life would be discontinued. And then in the middle is really a category that's often called as much good time as possible, where patients, families, and clinicians are really trying to find that balance between prolonging life and optimizing comfort. And this is often the category where many of our patients fall, and it requires often the most nuanced advanced care planning discussions so that we can adequately help guide decision-making for these patients and families.
The ultimate purpose of advanced care planning is also to achieve the best possible balance between 3 ethical principles, such as autonomy, beneficence, so doing good, and non-maleficence, avoiding harm, while also reflecting the values and the preferences of the child and their family. It's possible that some values may be in tension with others, for example, survival or freedom from suffering. And given that there's so many various individuals involved in these discussions, it can at times lead to times of conflict. So it's important as part of our advanced care planning to prioritize these competing values, address them early on, work out that what matters most for the child in the specific circumstances that they're in, and determining the overall goals of care on that specific basis.
All the benefits of advanced care planning are in some ways quite evident. I did want to spend a quick moment to highlight some of the main benefits for both the patients and families, but also for healthcare providers. First and foremost, it's really important to note that while these conversations are often difficult, research shows that patients and families are often already thinking about these topics. And even if they aren't, research shows that patients and families are typically appreciative of the conversation being brought up by the healthcare provider. From a patient standpoint, advanced care planning has been shown to decrease time in hospital, to lead to fewer emergency department visits, and to improve quality of life and symptom management. From a family perspective, parents who participated in advanced care planning were reported to be more prepared for the child's last days of life, had decreased caregiver stress and burden, and had decreased parental decisional regret. And then lastly, from a healthcare provider standpoint, advanced care planning has been shown to reduce healthcare provider moral distress by providing some clarity regarding family members' wishes during crises. Now that we've gone through what advanced care planning is, what goals of care conversations are, and what the benefits to both of these are, we get to the much more challenging part, which is really having the conversation with patients and families. And so given the recognized challenge of these conversations, research shows that a conversation guide is really helpful framework for both healthcare providers and families in order to provide language and flow to support these conversations. Conversation guides have also been shown to ensure that appropriate topics are addressed. And research also shows that these guides help clinicians focus more on listening in these conversations because they're less worried about what comes next in the conversation in terms of preparing and ensuring that they get all of the information they require. There's no gold standard that's been identified for a conversation guide, but the CPS statement does reference the freely available Pediatric Serious Illness Conversation Guide, which is published by Connect Place Children's Hospice from BC, and that's the screenshot that's here. It's based off a serious illness conversation guide for adults, which was developed initially as a structured communication tool that provides healthcare providers with a stepwise conversation guide, as well as psychologically informed useful phrases to use throughout the conversation. So you'll see here that they have a lot of sort of prompts for the healthcare provider in order to use phrases that have been evidence-based to help with these conversations. This guide is available as a 2-pager through the CPS position statement. And of note, there's also an associated online course and an in-person skills course that the CHEO palliative care team is now offering throughout the year. And so we really encourage everyone to participate in that. In addition to this resource, the CPS statement also has a very broad overview recommending 3 sequential steps to establishing goals of care with patients and families. So first, they note that it's really necessary to ensure that there's an accurate understanding of the current medical situation and prognosis to ensure that goals of care and decision-making are being based on an accurate representation of the child's health. Because if the patient and family don't necessarily understand where they are at in their health journey, the goals of care conversations really won't be reflective of what the reality of the situation is. The CPS statement then recommends to share this information about the medical situation in a compassionate but clear manner, to take time to answer questions, clarify misconceptions, and then when uncertainty exists, to provide a professional opinion based on the best available evidence and clinical expertise. So really recognizing that there's not always a clear path forward. Once an accurate appreciation of the clinical situation is established, physicians are recommended to then explore with patients and families what matters most to them based on their values, their hopes, their beliefs, and their wishes. After that, it's really the responsibility of the medical provider to take the what matters most information and to operationalize that into goals of care and use that information to make treatment recommendations that align with them. And the thought is that in using this strategy, it really avoids the scenario where a provider may be listing treatment options such as intubation or CPR for a decision maker who doesn't necessarily have the medical knowledge or experience to understand if that treatment actually does align with their goals. And so these 3 steps are captured in a table in the position statement.
So although the CPS statement is a great reference resource in terms of understanding a little bit better how to approach goals of care conversations or advanced care planning conversations, we do recognize as well that these conversations must be individualized to each family circumstances and the patients themselves. And so here are a few more important considerations to consider. 1, families should be encouraged to reflect on their religious, cultural, and personal beliefs in every goals of care conversation. And that as healthcare providers, we should allow the inclusion of additional supportive persons for them, whether that's other family members, friends, or community partners, as needed by the families or the patients themselves. It's also important to recognize that decisions should be considered as dynamic and flexible in nature, meaning that they can potentially change from comfort care through non-resuscitative medical care to resuscitative care as the clinical condition of the child changes. And again, as healthcare providers, we should be aware that each alternate decision maker may have different beliefs, even with similar cultural and religious backgrounds that exist within and between families. It's also important to note that spirituality and religion are not the same. If the alternate decision maker or guardians do not identify as being part of a certain faith, but they may still have spiritual beliefs and practices that are important to them. Spiritual care should therefore be routinely offered to all families, recognizing that each family will ultimately decide whether such support is appropriate for their specific circumstances. Therefore, the use of hospital and community cultural ombudspersons should be supported in accordance with the family's wishes. There are also some resources that we can use as healthcare providers, such as the FICA or the HOPE spiritual assessment tools to help us guide those spiritual and cultural discussions with families in terms of goals of care discussions.
So next, we're going to review when these discussions should take place. Advanced care planning and goals of care discussions for children and youth are most often initiated in times of critical illness, typically in response to an anticipated risk of death. In such situations, the transition to a palliative focus may be sudden, aimed at avoiding prolonged dying and limiting non-beneficial or potentially harmful interventions. When initiated during a life-threatening event, goals of care discussions often focus on setting limits or evaluating the appropriateness of a life-sustaining treatment. These conversations, while necessary, may be met with resistance. Capable pediatric patients or substitute decision makers might be reluctant to engage. Some may downplay concerns by noting they've overcome similar situations in the past, while others may feel alienated if recommendations are made by clinicians unfamiliar with their child and based solely on their current severely ill state. Even parents who recognize the limits of medical interventions may still feel compelled to keep fighting, viewing it as an expression of hope or a moral obligation to never give up. These discussions are often more effective and better received when they take place early in the disease course, before a crisis unfolds. It's like preparing for an emergency while still on the tarmac, rather than trying to make difficult decisions once a plane is already in the air and experiencing serious turbulence. On the ground, there is time, clarity, and perspective to make thoughtful decisions. In the air, under stress and urgency, choices are far more difficult and emotionally charged. Still, sometimes these conversations must happen mid-flight, and while more challenging, they can still be meaningful and lead to compassionate value-based care. By initiating these conversations early, healthcare providers create space for patients and families to reflect on their values, beliefs, and goals when the prospect of death still feels remote. This approach reinforces the idea that treatment decisions should be based on more than simply prolonging life. It's about aligning care with what matters most to each child and family. So, there is growing consensus that the responsibility for initiating advanced care planning discussions lies with healthcare providers rather than patients or families. While parents often express the need to feel ready for these conversations, many acknowledge that there is really a good time to begin them. Some prefer to engage in these emotionally challenging discussions when their child is stable, while others find it more appropriate during or shortly after an episode of acute deterioration. Signs that a patient or family might be ready include thinking out loud about the future or expressing worry. So, for example, if they say, "How will I take care of her as she gets bigger?" The other thing is if there are what if questions, such as what if this new treatment doesn't work? And last, if there are concerns about quality of life or suffering. So, for example, if a family says, "We never see him smile anymore, I just feel like he's unhappy." Or if a patient says, "I don't want any more chemo, I'm tired of feeling sick all the time." In these scenarios, if we were to switch to the next slide, we can consider probing using open-ended questions. So for example, you can say, how do you feel about your child's quality of life? Or are there aspects of your child's health that worry you? Or you can say, what's most important to you as things start to change? And last, have you been thinking about what will happen if things get worse? Goals of care should be revisited regularly, especially after major health changes. As a child's condition and quality of life evolve, family perspectives may shift. Even those once focused on prolonging life may reconsider in the face of suffering. Framing these discussions as ways to provide the best care in a changing situation fosters openness. Importantly, families prefer to engage in advanced care planning with a trusted healthcare provider who is familiar with the child and their underlying illness, and who will lead these conversations sensitively and compassionately. So here's an example advanced care directive template at CHEO, which of note will be likely modified in the future. For each intervention or treatment listed on the right, the patient or substitute decision maker should indicate N for interventions or treatments that are no longer desired, D for interventions or treatments that are desired, or E for interventions by oral or enteral route only. So for example, no IV. So some of these interventions and treatments include simple diagnostic tests, invasive diagnostic tests, chemo, feeding support, non-invasive respiratory support, mechanical support, CPR, or allowing natural death. So pediatric advanced care planning presents unique challenges distinct from adult care. Clinicians often care for children too young to express their wishes. They must collaborate with parents as surrogate decision makers and manage rare conditions where prognostication is uncertain. Complex team dynamics and inconsistent communication amongst providers further complicates the process. And studies have identified clinician-perceived barriers such as limited knowledge of the patient or family, timing uncertainties, fear of causing harm, and a lack of communication skills training. And then from the family and child perspective, barriers include limited prognostic awareness, religious and cultural beliefs, unclear preferences for involvement, strained family dynamics, poor communication, power imbalances, and a shared tendency to avoid difficult conversations. Together, these factors can hinder timely and meaningful advanced care planning discussions. Goals of care and advanced care planning discussions should ideally be led by the healthcare provider most involved in managing the child's most significant medical issues. On the next slide here, you can see the bow tie model of integrated palliative care, which highlights how palliative care spans the full disease trajectory, from diagnosis and treatment to survivorship or end-of-life care. Early integration supports timely and compassionate goals of care discussions, ideally starting soon after diagnosis. Most tertiary care centers in Canada have palliative care teams to support this process, including our wonderful pediatric palliative care team in Roger Nielsen Children's Hospice here at CHEO. It's critically important to document the key elements of any advanced care planning discussion, even if a final plan has not been made. Simply noting that the topic was introduced can be valuable for clinicians who may be involved in caring for the child during a future crisis. Accessible documentation also increases the likelihood that patients' goals and wishes are respected. Legal documents outlining care preferences and naming substitute decision makers are often called advanced care directives. However, most Canadian jurisdictions do not recognize advanced care directives from capable mature minors. So only 5 provinces, New Brunswick, Newfoundland and Labrador, Ontario, Prince Edward Island, and Saskatchewan, set 16 as the legal age for advanced care directives or expressed capable wishes. Importantly, advanced directives are only legally binding when made by individuals for themselves. Healthcare providers must follow valid directives from a previously capable adult. In contrast, documents created by parents and providers to guide care for an incapable child still require consent at the time of implementation. Even without legal standing, written records that clearly express end-of-life care preferences hold significant clinical value. Pediatric patients and families benefit from the opportunity to reflect on goals of care, especially in the context of serious illness.
Perfect. So now let's go through our cases. So we'll start with case 1. So this is a 15-year-old adolescent with end-stage cancer who failed multiple courses of chemotherapy and bone marrow transplant. They have been transferred twice to other hospitals for new research protocols, but the disease continues to progress. You're meeting with the family during an hospital admission where the patient is deteriorating pretty fast and further. Parents want everything to be done, but you have not yet had the opportunity to discuss with the patient. There is an ACP on the file, but it's been written more than 3 years ago. How do you approach this situation? Pediatric patients should be involved in participate in serious illness discussion, even if they lack decision-making capacity. Parents and substitute decision makers should be encouraged to observe, listen to their child's voice, behavior, and body language, especially in young or nonverbal children. Doing so not only honors the child's dignity, but may also ease the emotional burden on parents who sometimes feel like they should help guide their child in the decision, or when they feel like they need to take the decision. So let's review some recent literature on the topic and legal consideration. One of the challenges that healthcare provider can encounter is what you do when there's a difference of opinion between the parents or legal provider and the child. How do you approach the situation when the child can make their own decision on the subject or cannot? And let's review that. So currently, minors have the right to consent or refuse life-saving medical treatment if they have the capacity to consent. So in Ontario, consent is not age-based. Physician must determine if the child has the capacity to consent. And as a reminder, in Quebec, the age of consent is usually 14-year-old. So how does a physician can determine if they have the capacity to consent? So as per CMPA, there need to be reasonably confident that the child understand the nature and effect of the treatment and understand the consequences of refusing the treatment. So at what age should children be involved in the discussion? So there's no magic number when we review the literature. There's one systemic review by Blatman and Wolf in 2013 that mentioned that as soon as 10-year-old, the patient can understand and demonstrate an understanding of discussion of end of life and death. Studies show that adolescents wish to be involved without excluding the parents, which makes the role of the healthcare provider even more beneficial, as we mentioned earlier, because they need to be able to facilitate those conversations. So now, with that being said, how can a physician be reasonably confident that the child is ready to be involved? What tool exists to help, and what should we be taking into consideration? So there's one systemic review by Brunetta in 2022 that identified 4 cognitive domains that the physician can try to understand and see if the child has that. So on the basis of this theory, implying that children can understand concept of life and death as soon as 5 to 6 years old, we should involve them as soon as possible. And they should not be excluded from the topic. So there's 4 different domains that were identified. First, communicating a choice, understanding, which start about around 5 to 7 year old, reasoning, so from 6 to 8 years old, and which further develop in adolescence, and then appreciation of the concept. So adolescence starts to develop that social identity and awareness of themselves. So it is very important, as we mentioned earlier, to involve them as soon as possible. It's also very important to consider ethic background, as it does impact the age appropriateness of ACP involvement. So what tool exists now? So there's one tool that exists that it's called Voicing My Choice, which is a tool that is a self-paced tool that patient can use to explore different questions based on different domain. Again, so this study by Bedoya in 2022 wished to review that tool and see if it was beneficial in helping navigate those conversations. So they observed that this tool was very beneficial because it facilitated deeply honest conversation between the patient, the family, and the healthcare team. They did find that it was emotionally difficult to have those conversations, and it can create more worry, but having support of the health team could alleviate some of that. So they showed the importance of early discussion and beneficial for ongoing conversation. It shows that it was very positive for changes in relationships. So it was an opportunity to discuss an opening line of communication. It increased the feeling of closeness between the patient, family, and the healthcare team. It increased the knowledge about patient preferences and values. And in some, it changed the perspective of the family towards the patient, and in a positive way. And the element that were mostly shared were preference and comfort and support, care preferences when critically ill, planning for remembrance, and care and concern for others after death. So Voicing My Choice here can be used as a tool for adolescents.
So we just wanted to share one last study about this topic since we thought it was interesting. Hansen et al.'s 2022 study examined advanced care planning preferences amongst adolescents with heart disease and their caregivers. So adolescents aged 12 to 18 years with heart failure, cardiomyopathy, or heart transplants and their caregivers completed self-administered questionnaires assessing views on the timing and content of advanced care planning discussions, their communication preferences, and emotional responses. In total, 62 adolescent caregiver dyads participated, and most adolescents, so 75% of them, and caregivers, 61%, agreed that advanced care plan discussions should begin early in the disease course. However, there were key discrepancies that emerged. So 92% of adolescents wanted to be informed of a terminal prognosis, compared to only 43% of caregivers who supported this. Additionally, 61% of caregivers believed advanced care plan discussions would cause adolescent distress, whereas only 31% of adolescents felt this way. These findings highlight a shared desire for early advanced care planning, but differing views on prognosis communication and anticipated emotional impact. Thus, facilitated triadic conversations between adolescents, caregivers, and providers may help to align goals and communicate preferences.
So now let's talk about another case. So you have a late preterm neonate that was born at a level 2 NICU by emergency C-section for fetal bradycardia. At delivery, was born flat and required a prolonged resuscitation course and was found to have an abnormal neurological exam. That baby was then transferred to level 3 NICU, found to have a devastating intracranial bleed on the head MRI. And then, so therefore, neurosurgery, neurology, and palliative care services were consulted prior to baby arriving to the level 3 NICU. And given the findings on the head MRI, this baby's prognosis was deemed guarded for survival and long-term neurodevelopmental outcome. So how do you approach this situation? You would use a holistic approach. That's what is recommended. You would want to focus on the quality of life of infants with the life-limiting conditions. You'd want to treat every infant and their family with dignity and respect, regardless of their physical or intellectual ability, gestational age, or size. You want to embrace the physical, emotional, social, cultural, and spiritual foundations of care. You want to ensure that the infant is treated within the context of their family, and you want to make sure that the values and beliefs of the family are explored and supported in a model of shared decision-making. And I'd like to redirect your attention to the specific image on the left. So here you have the neonatal palliative care guide for neonatal intensive care units. This is this was published in 2020, so quite recently, by the Alberta Health Services. And it's a document that provides information to healthcare providers with consensus-based guidance on best palliative care practices for infants with life-limiting conditions and to support their families served in NICUs. And this specific guide was the combination of healthcare providers, allied health team members, community partners, spiritual leaders, and even families of patients who were all involved in the development of this guide and to create consensus-based guidance for the best practices. And so goals of care for a given infant may change during the course of his or her treatment. So here there's another image about the various palliative care pathways and the relationship between palliative care and the treatments aimed at cure or prolonging life. So on the first one here, the white part is considered curative and the blue part is considered palliative. So as the illness progresses, the emphasis can gradually shift from curative to palliative treatment. In the second row here, you can have highly technical invasive treatments that can be used to prolong life or to improve the quality of life alongside palliative care, each becoming dominant at different stages of the disease. You can have certain circumstances where there's no cure that's possible and it's palliative from the time of diagnosis. But sometimes in our clinical scenarios, at first it cannot be apparent that this will be a terminal illness, and palliative care starts suddenly once that realization becomes more clear towards the end of that specific infant's clinical course. So again, a team-based approach is key. You want to make sure that alternate decision makers or guardians are viewed as the primary caregivers and should therefore be involved as partners in the care of their hospitalized infants in the NICU. The ADM or guardian are the surrogate decision makers and what treatment choices are perceived to be the best in the best interest of their infant. As healthcare providers, it's our job as the healthcare team to provide the alternate decision makers or the guardians with timely disclosure of their infant's condition, but especially in an environment that's appropriate to the situation. And we have to recognize that treatment decisions may evolve over time, dependent on the infant situation, the information itself, the parent, ADM, or guardian's understanding, and other factors. So a multidisciplinary approach to care should be promoted and include healthcare providers who work within and outside of the NICU environment. So how does end-of-life care look for infants specifically? So there's quite a few little considerations that are important. As the primary healthcare provider, you should offer end-of-life care options in hospital or in the infant's home when possible and after discussion with families. If a decision is made to pursue end-of-life care within the hospital, different care environments should be explored with the family for their appropriateness. For example, the NICU, postpartum rooms, pediatric units, rooming in rooms, outdoor spaces or gardens, indoor spaces, or other available areas. Hospice care may be an option for families depending on the family's location as well. Second, so physiological monitoring during end-of-life care must be discussed with families. And so those include non-invasive cardiorespiratory monitoring, recognizing that some families may prefer to keep monitors on. It also includes invasive clinical activities such as routine blood work, monitoring wires, saline lock IVs, or ports that are no longer needed where possible needs to be discussed as well. And monitoring the infant for signs of distress and monitoring them for the dying process by such activities as intermittent auscultation of the heart are all part of considerations about physiological monitoring for infants specifically. Warmth and contact is also very important. The healthcare team should offer skin-to-skin contact or close contact according to the ADM's or the guardian's preferences. You can also provide warm blankets or cuddle cot to keep the infant warm and comfortable. And you also want to provide warmth and contact for the infant if the ADM or the guardian is unable to hold their infant during this process. Finally, symptom management. It's common for families to feel fearful that their infant may experience pain and suffering as death approaches. It's our job as the healthcare provider team to acknowledge the ADM and the guardians and or the family's fear and reassure them that the team will be present to continue caring for their infant and to do everything possible to make sure the infant is comfortable at all times. Now let's talk about transition of treatment to comfort-focused care. So reasonable considerations for transition of treatment to comfort-focused care can include any medications that do not contribute to the comfort of the infant, narcotics, boluses, and or infusions, benzo bolus or infusions, anti-seizure medications, and other medications contributing to the solace of the infant. However, medical treatments that are deemed appropriate to continue can include oral and endotracheal suctioning, enteral or parenteral nutrition, antibiotics, and routine bedside care, such as diaper changes, bathing, mouth care, etc., should be continued through the dying process unless signs of discomfort are apparent during their provision. And all of these should always be discussed as well with the family. Now let's talk about bereavement. It's important to recognize that as the healthcare provider team, we should support the families and any other family member involved in the bereavement process, not only after the passing of a child, but also plan prior to the anticipated passing of an infant or child. It's important to offer the ADM or the guardians and the family the opportunity to participate in those steps before and after the death care, such as bathing or dressing the infant, the creation of mementos, and using specialized cooling blankets and cots to help preserve the infant's body after death where available. These can be used to extend a period of time the infant can stay with the ADM or guardians for as long as the ADMs or guardians request and or preserve the body for autopsy as needed. If available, each family should meet with a social worker who can provide support, help with communication strategies, should they have living children, navigate extended family concerns, identify resources for funeral or memorial planning, and refer to ongoing bereavement counseling. If the death occurs before the infant has been named, healthcare providers should explore preferences for naming with the family, ADM, or guardians whenever possible. Wherever possible, the ADMs or guardians should not have to leave the hospital with empty arms. Some mementos that may accompany the ADMs or guardians when leaving hospital include a stuffed toy, a blanket used by the infant, and or a memory box, or also footprints. Photography should be offered to all families, ADMs or guardians during the end-of-life care and or bereavement periods. It should be recognized that for some families, however, photography will not be appropriate and those wishes need to be respected. ADMs or guardians should also be offered the opportunity to create mementos of their infant's life. A conversation around the importance of these keepsakes in their grief journey can be helpful. A memory box can be created with tangible items that have meaning and have been part of the infant's life, including hospitalization. ADMs or guardians have the right, however, to choose whether they want a memory box or not, and their wishes should again be respected if the memory box is declined.
So in summary, advanced care planning benefits all involved and is an essential responsibility of pediatricians who play a key role in supporting families through complex decision-making. These discussions should begin early, especially for children with serious or life-limiting conditions, and must center on the values and beliefs of the patient and family. Ideally, they should be led by the healthcare provider most involved in managing the child's most significant medical issues, as this continuity supports trust and informed guidance. Many clinicians would benefit from more training and practice to approach these conversations with confidence and sensitivity. And several helpful resources are available, including the national guidelines and communication tools to help support these conversations. So thanks so much for listening to our presentation. We'd be happy to address any questions at this time.
We'll wait 10 seconds for the audience before I ask my question.
Looks like Dr. Zar has a question.
Yeah, thank you. It was a great presentation. I wanted to ask you in your research and looking at the literature, how much evidence did you find for nature experience in ACP?
Are you cut out a little bit? So we heard how much evidence did you find in terms of, and then I didn't hear the last.
So sorry, sorry, let me see if I can get better reception where I am. Sorry about that. Is it better now?
Yeah.
Any better now? Yeah. Okay. So yeah, I just wanted to know, in your search of the literature, how much evidence was there at all, if any, as to the role of nature in ACP, nature exposure, so the continuum between nature exposure and nature experience.
So,
Oh, sorry, go.
no, go ahead, yeah.
I was going to say, from what we were looking at, I don't think any of us identified any specific studies looking at that. Dr. Kumar is also here, who was one of our supervisors, so I'm not sure if he knows of any literature on that topic, but nothing that came up for us.
Yeah. Okay, I would just ask that, yeah, if anybody does, I'd love to have that shared with me. I know there's quite a bit of literature on the role of nature interventions, and I just personally haven't seen a lot specifically focused on palliative care and end of life issues.
Yeah, so there's a little, I don't know about peds, and I don't know in the last 3 or 4 years if there's been an update. There's more literature on the adult side.
Okay.
Looking at practices though, so in a lot of North American hospitals, spaces have been created particularly around NICUs, that do involve nature somehow. So there are places where babies have been kind of exposed to nature, where it's an indoor glass room or something where kids can be exposed to nature as they're dying, or sometimes it does come up as a family wish. I think it would be a good opportunity to revisit this and see if there has been any update. And if not, is this something we can actually write about, publish about, or encourage people to even think about that? So really good point.
Awesome. Thank you so much.
I see in the chat that Dr. Bouchard is pointing out that Dr. Czar is a certified nature therapist. Cool. My question was this. So right now, for patients who have an advanced care plan at CHEO, is there a sort of a standard place that one would look if I'm seeing this patient for the first time and I want to know that? I'm thinking of that from the eMERGE perspective. We have T files for patients with complex care. And I'm wondering if that's where I would look to see about an ACP, or if that's an area we need to work on.
Yes, it's around the same location as T files on the left side of the chart in Epic, usually. I'm not sure if Dr. Van Zanten was going to comment on it as well.
It was, yeah. So anyone who has an advanced care plan in place, regardless of who's done it, should have a flag on the left-hand side of their chart. It's like a red little flag that says ACP on file. And when you hover over that flag, it should tell you the most recent ACP note. And so you should be able to see that. I will say that we are revising the ACP policy at CHEO right now. It's just in the final stages of revision. But just for general review, anyone can have an advanced care planning discussion. So if you're in the NICU, the PICU, the eMERGE, if you have a discussion, let's say the person has never had an ACP conversation documented to your knowledge, you would do your normal documentation, and then there's a drop-down menu that says note for ACP note. So you specifically have to write an ACP note and then put it in order for ACP on file. And that order for ACP on file is what will put that flag in the chart for so that it's visible to everyone. And that's how and if you were to update it, that's the same way. But once they have an ACP on file, you can update an ACP note, if that makes sense. And then the only other second thing, that this is a logistical thing, but that palliative care directive, that one with the degree of interventions, yeah, you're going back to it, thank you. If you're having, so really that form is mostly designed for our palliative care team. And so yeah, this form here. So if you are having an advanced care directive discussion, we do not expect you, or you do not need to fill out this form. It doesn't make sense in most of the contexts that most of people would use it. We use this more for our chronic palliative care patients, where we review it once a year. So really it would suffice to write an ACP note and have that ACP note in that corner that just basically says does not want admission to PICU, no intubation, no CPR, discussed with both parents on this date. Kind of a short, succinct thing. So stay tuned for that policy. It's very exciting and coming out soon. But yeah, happy to answer any questions or provide sort of written documentation or written guidelines. My email's in the chat too, so can send that out as well if that's helpful.
Yeah, thanks. That's extremely helpful. The idea that in the ED I could be potentially maybe updating these if something happens, or that I could be creating them, that would be, I think that would take what we're doing now up a level for sure. Thanks. Any further questions or comments from the audience? Just seeing some praise in the chat for a great talk. All right, well then, with that, oh, Chris, hand up.
Yeah, I'm just wondering, I think each of you who presented today did a great job presenting, by the way, but have gone through the serious illness conversation process. I wonder if you want to share how that was, if it was stressful, if it was useful, any pearls you took away from that.
So I can maybe start off by talking about, I went through the course through our academic half days in this past fall. And I thought it was super useful because it provided a kind of a structured framework. And I felt like because I was less focused on kind of figuring out exactly which words to use to ask kind of those questions, or kind of what was the next question I had to ask, that I was able to focus more on the conversation and actually gathering what matters most to families. Since you basically, I think you just put it up on the screen, you basically kind of go through the process, and they have example wording for kind of each stage about how you can kind of bring up the conversation starter.
I would
both,
echo what, oh, sorry, go ahead, Jasmin.
I was going to say, I think both myself and Mia, we've done like the online portion of it, but we haven't completed the in-person portion of it yet. But we're looking forward to it when the next session is available.
Same for me.
And even the online portion is nice in that it has lots of videos of practitioners doing these conversations with families, both in terms of sort of positive ways and rooms for improvement. And so it gives you a lot of insight as to sort of where things may be derailed and how to bring the conversation back.
All right, well then, I will thank once again the audience and the presenters for making a very interesting dynamic today and for giving us some information we didn't already have, I think, for some of us on this important topic. Have a good day, everybody.